So today we have Dr. Wickott presenting again, and she will be speaking on post-acute care. So please welcome Dr. Wickott.
Thank you, Lindsay. Appreciate it. So I know some of you were able to be with us last time when we talked, as Pam reminded us, talked through the acute hospitalization phase, and a reminder of what an acute hospitalization is, and that's when you are needing the services that only can be provided in an acute hospital setting. And now we're going to be talking about what happens next when the time for discharge comes. And so what I've done is I've taken us back to the very end of the slide presentation that we were working on at our last presentation. And that is, now that you're at the point of discharge, you're at three options. You can discharge from the acute care environment and go home. You can go to a skilled care, or you can go to long-term care. Now, those are not necessarily places. Home pretty much is a place. We'll talk about that as well. But those are categories of care, and that'll make more sense as we go into today's conversation further. Oh, sorry. So, and again, we're back to where we were at the last presentation for a little duplication for those of you that were here last month. But the decision for discharge has to do with your readiness to leave the hospital because you no longer need the acute care that can only be provided in that hospital environment. It is not a decision around your readiness to return home or return to the level of function that you had prior to the hospitalization. This decision of going from a hospital has only to do with, do you still need the services that can only be provided in the hospital? And that is a really hard thing to grasp, to get your hands around. Even for people who work in the environment, it's hard to recognize that distinction. When we do make the decision, again, the highest priority of what happens at this decision point has to do with the safety of the patient. So it's obvious, if you're not ready to go home, it's not safe for you to go home, but you don't need to be at the hospital anymore. I know I'm saying it again and again, but it's a tough concept to get. So what if I'm not ready to go home? This is how we ended our conversation a month ago. And so now we're going to talk about post-acute care. So this circle was introduced at our last presentation, talking about kind of what I've dubbed the seasons of care. So you either are in your steady state, which is where we all are right now. It's where we all want to be, desire to be, and we would hope that everyone would be able to stay there. But on occasion, we can't. And we find ourselves in a hospitalization setting, and that encompassed our conversation last month about what an acute hospitalization is. And now there's that scenario of the post-hospital stay. For some people, that post-hospital stay is you just barely pass through there and you're right back to steady state. The majority of our folks who come through a hospital environment, they spend some amount of time in this post-hospital transition time before they move back into their steady state. So the question, why can't I just stay in the hospital until I'm ready to go home? I'm using the word home because home might be a nursing home, home might be a skilled nursing facility, home might be assisted living, but it's really where they came from before. So that decision really is all about how payment occurs. So we're just going to spend a little bit of time talking about how the dollars flow, because that is what's pushing these decisions. That is what is pushing why it is that the reason why you're leaving the acute care setting is because you no longer need the services that can only be provided in that environment. And it has to do with the payment. The payment is over with. So in a PPS hospital, I won't burden you with what that means, but other than to describe it as the usual hospital, the one that most people are familiar with, contrasted to a critical access hospital, which is what we are here in Snoqualmie Valley Hospital. So those are the two options, and then I've also just thrown the physician line in here. But a PPS hospital, Medicare has been established as the standard or as the reference point for how payments are made. So a commercial insurance payer will mimic often what Medicare does. Medicaid will often mimic what Medicare does. Maybe not, definitely not in the dollar amounts, but in the guidelines and the regulations and the processes here. And so we'll use Medicare as the basis of our conversation. And so with Medicare, there is a pre-established amount of money that is going to be paid to take care of a person when they're in their hospital stay. And that amount of money is pre-established, and it is determined based on the reason for the admission. So I'll give you an example. Somebody came to the emergency room. They were having a fever and difficulty breathing, and their chest was uncomfortable. So they came to the emergency room very wisely because they didn't know what the cause. Maybe it's my heart, maybe it's my lungs, maybe it was the wood that I was chopping yesterday. You know, you can imagine what all of those thoughts are. They were admitted to the hospital, initially out of concern that it might have been their heart, but then in the course of the next 24 hours, it became clear that what they really had was a pneumonia brewing. So in the end, the reason for that person's hospitalization was pneumonia. And in the Medicare tables, it is really that simple. There in the Medicare tables, there is a dollar amount that will be paid by Medicare to the hospital to care for a patient with a diagnosis of pneumonia. If in the course of that hospital stay, this patient that we're talking about develops a urinary tract infection, they have something horrible, they have a stroke while they're there, you know, that was going to happen at home too, but it happened at the hospital, that payment, and that payment's called the DRG, that doesn't change because the reason that person was admitted to the hospital was pneumonia. So you can start seeing how managing your admission is very important to hospitals. And that's why there's an intense management on length of stay, because the longer a patient stays in the hospital, it's no different than the longer you stay in a hotel. It costs more money the more nights that you stay there. So the longer you stay in the hospital, the more money it costs for the hospital to provide that care. And so a hospital that relies on that money that is given to totally pay for the care, they are going to need to manage that as best they can. Now, a critical access hospital, just to do a contrast and then to be complete on the two different payment methods that are out there, a critical access hospital has a payment that's actually based on what it costs to provide the care. So this was the old way of doing things. So the PPS hospitals, DRGs, that predefined amount of money given for a diagnosis, that came into existence in the 80s. So prior to that, everyone was paid based on the amount, on what it cost to provide the care. So critical access hospitals have retained that methodology, and then PPS hospitals have been pushed to move to a DRG-based payment system. There are methods in place, though, for maintaining a reasonableness factor. So just so that it doesn't appear that, wow, critical access, that's an opportunity to run away, and just with your charges, there is a reasonableness factor that is in place that standards you have to adhere to. Physicians, and just to throw it out there, physicians are paid separately from the hospital, so the DRG payment or the cost of care, there's an entirely different fee schedule for physicians, paid based on the level of service that they provide on a daily basis. But this is some insight into why the length of stay is managed, and why as soon as a patient is no longer requiring these services that can only be provided in a hospital setting, that it's time to move on to a different. That's our conversation today. What do we move on to? What are the options there? So these are I moved it one more if you don't mind. We talked again about discharge to these groupings of home, skilled care, or long-term care. And the ones that are highlighted in green on the screen are the ones that are post-acute skilled services. So skilled services means that you need someone who is of a licensed type in order to provide the skilled care. So whether that be skilled nursing care, skilled rehab care, so we have physical and occupational therapy, skilled wound care, that's back in the nursing realm, and physical therapy laps over into that. But so that is the home with visiting care, which is a concept that Pam was introducing as she was introducing what her company does. And then there's acute rehab and subacute rehab, which is both nursing care and rehab care, so physical, occupational, and speech therapies in that. So if we just focus on home with visiting care, we're going to go through each of the 3 green areas. So right now, just talking about home with visiting care. Again, the realm that Pam was, the realm that Pam was introducing to us from her organization. So this is where in a home-based setting, so whether that be your own personal home, your children's home, a family friend's home, wherever that home-based setting occurs, can also be in a senior living environment. A nurse, a rehab therapist, I've got bath aid, social work, whatever those services are, they will actually come into the home and provide this care. 1 to 3 times a week. It varies depending on what the needs are and what can be justified. The visits are usually 45 to 60 minutes in length of time. The whole crowd doesn't come in at once. They'll have a nurse that has their schedule, the physical therapists have a schedule, and so over the course of a week, you will have quite a number of hours where somebody was in your house if all of these services were enacted. The criteria for this, and again, we are having a Medicare conversation that guides a lot of these rules, so some of these rules don't apply when it's a non-Medicare, but we're just going to use that as our standard of conversation since the majority of these services are taken advantage of by those in a Medicare population. So homebound status is a criteria here, which means you have to have these caregivers coming into your home to provide care because you can't leave the house yourself. Medicare defines homebound status. We won't go into that. There's a couple of reasons why you can leave. You can leave to go to the doctor's office. You can leave to go to church. But otherwise, you can't be going shopping. You can't be going to visit your kids. You can't be just going for a drive today because you're no longer homebound. So you actually, in Medicare's perspective, you could go seek these services on your own. They don't have to bring them into your house. Bringing them in is very costly, as you can imagine. Skilled services must be in place for non-skilled services to come in. And again, this is a Medicare conversation we're having, meaning if we were going to have a bath aid come in and Medicare was going to pay for it, they will as long as you have a skilled nursing or skilled therapy in place. If you don't want Medicare to pay for it, if this is a need that a family member has and you want to take advantage of it, you can always pay for these services on your own. There are companies that absolutely will do this for you. It's just not a Medicare supported service outside of having the skilled care in place already. And then the other criteria is a physician has to agree with the care plan. And there's been quite a few changes around this just to shore up that aspect of it in the last year. Yes, Jean?
What does that mean in place? Now, does that mean a registered nurse or LPN has to be there at the time?
It has to be, no, it has to be one of the services that you're participating in. So you have to be participating in receiving skilled care from a nurse, receiving skilled care from a therapist, in order for you to also receive non-skilled services. But it does not have to occur at the same moment in time. Acute rehab, just to keep us moving forward for time's sake. Acute rehab is an environment, it's a hospital-based environment, and it is for the purpose of physical recovery. And I'm delineating physical recovery from medical recovery. Medical recovery meaning a wound that you need to have managed, and long intravenous antibiotic administration therapy. Those would not typically be seen in an acute rehab environment. An acute rehab environment would really be focused on the physical rehab. So after a stroke, after accidents, really getting you back into a state of mobility and function. That's what acute rehab has their focus towards. They can manage minor medical issues, but they prefer not to. It clearly makes it much more challenging to put the amount of time and energy into the physical aspects if you're having to also manage a lot of medical issues. Patients need to be capable of at least 3 hours of rehab every day in order to be a candidate to go into an acute rehab facility. We do have several local examples. Evergreen, Swedish in Seattle, Virginia Mason all have acute rehab programs within their hospitals. We can talk more about it. We've had an opportunity to work collaboratively with them, so it's wonderful to have them in the area. University of Washington has an acute rehab program, so we've got lots of really good programs locally. So to be eligible for a rehab stay, and this is going to be a segue to the subacute rehab as well, so whether it's acute or a subacute rehab stay, to be eligible under Medicare guidelines, again, you need to have had 3 nights in the acute care environment. So they're counted by midnights. You have to spend the night, 3 midnights in an acute care hospital in order to be eligible to move on to an acute or a subacute rehab environment. I just want to reiterate again, this is a Medicare regulation. There are non-Medicare entities that is not their rule. They'll allow it after 1 or 2 nights. But I don't want to add the confusion to this. So the subacute, after having introduced what acute rehab is, subacute rehab is for those folks who need rehab services, but usually can't make it to the 3 hours. So this is focused not only on the physical rehab, but also now the medical rehab is included in this as well. So scenarios of somebody who's been in ICU for several weeks, and so they are physically debilitated because of that prolonged stay in an ICU setting, not getting up out of bed and such. And in addition, they had whatever medical issue brought them into the ICU that still needs to be medically managed and needing skilled nursing needs as well as skilled rehab needs. A subacute environment is an easier place for those folks to start their rehab than going to an acute rehab where so much focus and pressure is put on the physical, and they really are often not capable of those 3 hours. So moving them into a subacute rehab environment will get them launched. And very often when they get to the point of being able to do the 3 hours, you can still transition to an acute rehab. And so that's where you have the opportunities for collaborative. So we have, at our facility, we have a subacute rehab facility, and so we have the opportunity to interact fairly often with the acute rehab and move folks into that level. So I say that only because I don't want to present these as being silos that don't interact at all with one another, because that in fact is not the case. There's lots of opportunities. For subacute rehab, you don't have the 3+ hour requirement if you're able to do 3 minutes. Whatever you can do, that's where you can start in a subacute rehab environment. So a subacute rehab environment also has a lot of different settings. So that might be a hospital-based environment. It might be a nursing home environment. Traditionally, this is referred to as a SNF, skilled nursing facility, and usually within the walls of a nursing home. Local example for us is Mount Si has a skilled nursing facility within their walls. There are long-term acute care hospitals. I don't want to create confusion by explaining this in more detail other than it is intense care just like in an acute care environment, but it's for those folks who need it long term. This is maybe somebody who's on a ventilator who just can't get off. They're going to need longer to get off of the ventilator, and so that would be a scenario where Kindred or Regional, which are 2 hospitals in our local area. And then there are standalone subacute rehab facilities, and again an example of that is Briarwood down in Issaquah. I think the subacute setting does matter. And we talked about there are several, and there's a place for everyone. I think it's important to realize that there are differences between the settings. And I think the settings really are hospital-based and non-hospital-based. And so just to compare and contrast, in a hospital-based environment, because it is also an acute care locale, there's all of the ancillary services, and by that I mean lab, x-ray, pharmacy, social work, other outpatient services. Those don't necessarily exist in a non-hospital-based facility. Those services can be brought in, so especially lab, x-ray, and pharmacy, those services can be brought in, but they tend to be satellite or rotating through. They aren't permanently residing within the walls. The ratios of between patients and nurses, and please don't get caught up in the mathematical descriptions here, because I have a math brain and feels wrong for me to write it this way. But so the higher meaning less desirable, there's more patients assigned to each nurse in a non-hospital-based environment, whereas a hospital-based environment, there are less patients assigned to each nurse. You can do a more intense level of care in a hospital-based environment. What I mean by that is somebody can be more needy of skilled services, and those needs can be more easily met in a hospital-based environment. It's more challenging to meet those needs in a non-hospital-based environment. A non-hospital-based, especially one that's in a nursing home setting, is an excellent option for that person who it's really clear that they are going to need to transition into a long-term care environment. They're not going to be able to return to home. They're going to need long-term supportive care. So to already start that process, if they don't have the higher needs, that they would be better served in a hospital-based environment, doing something that is nursing home-based or associated with a long-term care environment makes one less transition that person has to go through. They can start settling in now. Physician on-site versus physician visiting is different. And then just the rate of return is it can't be avoided calling out that because a hospital-based environment can provide a higher level of care, it's less often that somebody has to return from a subacute status into acute status. That happens more often in a non-hospital-based environment, and it really has to do with they just don't have the services there. If somebody starts to get sick, to get it turned around. And it's not to say it's not a good place, not at all. So then when it comes time to discharge from this whatever rehab environment it is, whether it be acute or subacute, or even a home-based environment for rehab, the discharge is indicated by plateauing. Plateauing means exactly what you think it means, that you keep getting better and you keep getting better and you keep getting better, and then when you stop getting better, you've reached your plateau. It does not relate back to the level of functioning prior to the acute stay. So it is very common that someone who is functioning at wherever they are living prior to going in for their acute hospital stay, and they weren't functioning all that well. And we talk about frail sticks. And so they were a frail stick about ready to fall over. They had something happen, the pneumonia example, we'll just keep using that. And they went into the hospital, and then from the hospital transitioned into a post-acute location, subacute, acute rehab, subacute rehab. And now they're getting better. It is common that they bypass and they get better than where they were before they ever went into the hospital. And that's simply because of the attentiveness that's being given to endurance and core strength and what have you. That's a great outcome from a post-acute hospitalization or post-acute care hospitalization, that now when they go home, they are safer than where they had been in the months and sometimes years before they ever came into the acute environment. When the time comes for discharge, again, safety is the highest concern as you're making those decisions. Respect for patient autonomy, again, is honored. And again, this was a big part of our conversation last month, talking about while we have recommendations to make around what is safe, if the patient has a different opinion, their opinion is going to have to trump. If they say, I know you want me to go to this environment. I know you want me to have home care services. I choose against it. As long as they are competent, then their preference trumps, and we will honor that. And Medicare and Medicaid allow about 7 days for the transition out of this facility. So if you can think about what we were talking about, an acute care environment, those days you're managing hours, and you got to make a decision. We've got to move folks on out because we need to manage those days. Here you've got more time to play with and to make plans, again, for a safe transition. If you're going to go home, is home ready for you? Have all the grab bars in place? Are all the throw rugs off of the floor? How are you going to manage the stairs? So all of those things can happen in those 7 days. The 7 days is a Medicare, Medicaid usual time frame. Sometimes there's a little push that comes from non-Medicare, Medicaid carriers, so I didn't want you find yourself in a place of, if this became you or a family member one day, of confusion happening. So we're leaving post-acute care. We talked about this, the 3 skilled. So those are the ones that were in green before: home with visiting care, acute rehab, and subacute rehab environment. And now you're moving on to a non-skilled. So you're either gone through a skilled environment, or from your acute stay you're going to go straight into a non-skilled environment. So that can be home on your own, it can be going into a senior living environment, it can be assisted living, an adult family home, or a nursing home. So home is what almost every patient desires, and we all would be that way. Senior living tend to be apartments. They've got basic services included with that, meals, cleaning, activities in the building, but it's otherwise independent living within the apartment itself. And there's assisted living, and now that has layered on some additional services, medication oversight, maybe some personal care is brought in. This is a time when some visiting nurse services can also be incorporated. And then the next thing is an adult family home. Thank you, Mara. So an assisted living in a home-based environment. And so now you're getting into where caregiver ratios are higher than what was the case when assisted living or independent living. And now we come to a nursing home setting. So which everyone is more familiar with, extended care, continuing. There's still more seasons. If you take the circle and break it down into smaller fragments, the extended care environment can take someone on through what lies ahead. There is an increasing level of regulation and inspection, so you can imagine the person who needs to live in a nursing home environment as opposed to the person who is in their home or in a senior living environment. The farther you go down this list, the more vulnerable that patient, or in this environment they tend to be referred to as residents, the more vulnerable that person becomes. And so the need for more regulation, for more inspection, to be able to create and assure a safe environment in each of those locations. So just to bring us back to our circle, that once the post-acute, with hospitalization, the post-hospitalization stay is finished, and now we're going to return to the steady state. This steady state may be different than the steady state that was the case prior to the hospitalization. It may be the same, and it may be different, but it is a steady state nonetheless. And then the desire, again, is that the duration of time spent in the steady state is as long as possible. The desire is not that they re-enter the circle again. And part of preventing that re-entry of the circle actually is what happens down here at the post-hospital time, is how much support happens there to allow a transition into that steady state that is really back squarely on feet, capable of caring for self or being cared for at a level that puts you in a position of success, of staying there as long as possible. So I'm going to end there, and I know there's so much more detail lying beneath these, what we covered already, but once you start getting to detail, it starts getting confusing as to whether you're talking about Medicare, Medicare Advantage, commercial payers. So that would be better just to open up to questions. If anyone has a specific question, we'll dive down at that depth and regard. Yeah, I will. Mm-hmm. So Mara's question was, how will the things that we've talked about today be impacted by the Affordable Care Act that is in the process of going through its enactment? And I wish that there was a concise and clear answer to give to you, and there really isn't at this point in time. We're learning week by week, month by month, really where we'll be seeing the changes and the impacts of the Affordable Care Act. And you're exactly right. The goals around that are to put both carrots and sticks in place to prevent this rapid cycling and this return. Of the circle, the most expensive is hospitalization. So doing things to prevent the hospitalization and to prevent the rehospitalization is huge. And the Affordable Care Act, again, uses both carrots and sticks to try and prevent that from occurring. But we really will. These next 24 months, I think, are going to be eye-opening or just clarity. Because right now we're all just wondering. We know concept, but we don't know detail. And those are all the things that are coming into light right now. Good question. Maybe we'll brush this topic off and bring it back 2 years from now and see what the answers are. Anybody else? Yes, ma'am. Mm-hmm. Yeah, thank you, Jan, for bringing that up. Jan was reminding us that hospice care is another variety, and I would wonder if making it a fourth category or even going ahead and including it in home, because from a hospice perspective, as you're caring for somebody in hospice, you always want to consider where is home based on that patient's perspective. So we can provide hospice care both in a true home environment, again, whether it be the patient's home, a family member's home, a friend's home, and even an extended care facility, being where that care is provided, and from the patient's perspective, that is home. Being a hospice provider historically, that was very important and quite a priority for us, is that we recognize home. And when you recognize home, then you're also recognizing who is in the circle, the family circle, because it's not necessarily just the blood relatives when you're in an extended care facility providing hospice care, because all of the nursing staff, all the caregiving staff in that environment is now also family. Yeah, excellent point to bring in. Thank you. So Sue's question had to do with how does payment follow in that example that we used of pneumonia as they're transitioning on into subsequent care environments. If I'm hearing question, there is. Yes. So that admission diagnosis, what we call the DRG, that only applies in the acute hospitalization. So that limited dollars that has to stretch to cover, regardless of what happens during the acute stay, that only applies in the acute hospitalization. So now, when it comes time to transition to a post-acute care, so let's just follow the example that this patient with pneumonia who then had the stroke needs to transition into an acute rehab environment. Their admitting diagnosis to acute rehab is going to be their stroke, because that's really the reason for going in. The payment is now the payment process is entirely different in an acute rehab and a subacute rehab. You no longer are dealing with those DRGs. It's a different payment. Thanks. Sure. So Mara's question had to do about how do the families learn about what options are available as you're transitioning. Great point to bring out, and that often becomes a differentiating factor, but from one facility to the next, is how supportive they are in these decision making. Now, you'll hear horror stories of somebody saying, I was just told that I needed to figure out what to do with Dad and I needed to figure it out by tomorrow. Versus another person who will say, I had an excellent experience. I had somebody who partnered with me and had all this information for me. And so it becomes very facility based. There is not really a regulatory obligation to do that. I mean, there's a regulatory obligation to do the bare minimum. But what happens above the bare minimum is a matter of conscience of the organization. And I do think, back to your earlier question about where are we going to be able to see and experience the differences brought on by the Affordable Care Act, and I almost anticipate that to be one of them, because I think one of the outcomes of the Affordable Care Act is going to be some standardization of what we do and of expectations, and I really wonder if that won't be one of them, because I think that's one of the things that helps keep the cycle from spinning again and again, is to make good decisions the first time around. Good decisions meaning the best decision for the circumstance and the patient and the finances, on and on. Absolutely. Chris's question was, are we going to see more emphasis being placed on the preventing hospitalization in the first place? I think as we look into the next probably 5 to 10 years, we're going to really be seeing an emergence of the medical home model, which is an approach to how care is provided in the outpatient environment, and especially in a physician office setting. And that is exactly why the medical home model is coming about. Twofold. One is to increase access into the clinic, into the services that a clinic will provide. But a medical home model also places pressure or responsibility or ownership of that medical home service giver of preventing decline, preventing hospitalizations. And so it will be rewarding that medical home provider team with offering things that right now there isn't an incentive to do or a reward for doing. So if you think about, I'll do something in your world. So you've got the elderly person who's becoming more and more frail, but they really don't have a diagnosis. They're just becoming more frail. But as we all know who live in this world, we know that that frailty is going to result in an increased vulnerability to illness or injury, and that's a hospitalization. So having an opportunity to provide core strengthening, like you said, the SAIL programs, all of those things, to have those incorporated into the medical home model, to where actually it is part of the caregiving that you can provide and get reimbursed for. And that's what we're going to see with the medical home model. It's going to be an entirely different reimbursement process that now supports you in doing things exactly what you're talking about. Yeah. Any other? These are great conversation. You're good questions.